MOT 135, part 4. We're starting this part with the regulation of respiration, what controls our respiration. So the medulla oblongata in the brain has a centers for respiration. pH, or the acidity or alkalinity of the blood, is the main driver, and then carbon dioxide. Oxygen plays a very small part, but the main driver is the acidity or alkalinity of the blood, which makes us breathe harder. The main sources of data that the medulla oblongata uses comes from these various places. And again, this is not a substitution for reading the book. I do encourage you to read the book alongside the lectures in order to understand some of the concepts. The stretch receptors in the walls of the bronchi or the bronchioles. Maximum expansion stops the impulses from the medulla oblongata and forces us to breathe out and controls breathing that way. Proprioceptors in muscles, joints during exercise, increases the ventilation, depth and rate. So during exercise our cells are respiring and producing more carbon dioxide, and that forces the carbon dioxide levels to increase. Hypothalamus, limbic system, cerebral cortex, sleep, exercise and emotions. Our limbic system, of course, is to do with our emotions, and if we get scared, it increases our breathing rate. If we're in the fight or flight, we need that extra oxygen in order to make our muscles run away. And so sleep, exercise and emotions is all to do with the hypothalamus and the cerebral cortex. The cerebral cortex also has a small area of voluntary control where we can control, like holding our breath. We can breathe slower and we can control it that way and relax. But holding our breath is useful for when we're swimming, of course, if we want to go under the water for a little bit, or if you really don't want to breathe something in. But we can only do that temporarily. Holding our breath basically leads to passing out. When we pass out, our bodies relax, and then the medulla oblongata then kicks back in to make us breathe again. So holding our breath, holding our own breath voluntarily, does not make us die, unless, of course, we're underwater at the time. We don't want to pass out underwater. So typically we have all those systems in place to make us breathe. The peripheral chemoreceptors and the central chemoreceptors monitor the blood and the cerebrospinal fluid pH, respectively. So again, the pH, the CO2 and the O2 are in the central chemoreceptors. So pH and CO2 being the main drive for breathing regulation, we talk about some terms here: acidosis, alkalosis, hypercapnia, and oxygen again only plays a part when the oxygen levels are below the saturation point. We are regularly at saturation point, which is around 97%, 99% oxygen saturation. If we fall below that, typically then we get hypoxic drive and our breathing increases naturally. But usually that's when oxygen isn't even available. So it's hypoxic drive. So we give patients who are compromised because of disease, we give them oxygen tanks or oxygen compressors in order to give them extra oxygen when it's just not available in the atmosphere. The functions of the respiratory system are as they are in the book: gas exchange, and remember that smoking limits the amount of hemoglobin available because of the carbon monoxide taking up that space. So it limits the hemoglobin available for oxygen. So as a result of that, more red blood cells are produced. So many smokers, in fact all smokers, have too many red blood cells. Okay, so they have polycythemia. And that can cause its problems in itself. Also acid-base balance, which is the pH. The speech, it gives us from the larynx. So these are the structures that are the dual duty that I mentioned in the very first part. We have the nasal cavity, also gives us our sense of smell, of course, and the larynx gives us speech. And the creation of pressure gradients. So it helps us have those pressure gradients in order to regulate our breathing. So the functions of the respiratory system are basically these 5 things. Aging and tests. The effects of aging. There are 4 effects mentioned in the book, so just read about those effects of aging, which is aging without disease, but of course disease can add to these effects. And then table 12.2 talks about the diagnostic tests. You'll see that most of these, or you should know that most of these are blood gas tests, or they're blood tests, and tests for diseases, of course, or disorders of the lower respiratory system. So the CT can be used for anything, CTs, MRIs, all of that stuff, but you'll see an awful lot of those tests are actually to test for disease. And the disorders, they are summarized in table 12.3, but if you go through them and read them, and the applied genetics talks about cystic fibrosis and how that disables not only digestive processes, but also, of course, respiration, and how the excess mucus builds up and affects our lungs and the ability to gas exchange. The infections section, you can actually split it up into upper and lower respiratory tract infections, and there's only one there, pertussis. It really depends on how far down it goes, but the upper ones are basically cold, flu, pharyngitis, etc., and the lower ones are the ones that actually affect the lungs and the bronchioles. So acute bronchitis, remember the difference between acute and chronic. Acute comes on quickly and tends to go quickly. It's a temporary infection. Chronic bronchitis is disease of the bronchitis, of the bronchi, over time. So, and that belongs to the category of COPDs, chronic obstructive pulmonary disorders. And there are several of them, remember. There's chronic bronchitis, emphysema, and asthma. They are all considered to be chronic because they're over time, obstructive pulmonary disorders. Then it talks about respiratory distress syndrome and acute respiratory distress syndrome, which can come on suddenly depending on the situation. And we've already talked about that in babies. Cancers. Cancers can occur, of course, anywhere, especially in the respiratory system. And then others, which are things like cystic fibrosis, which sort of is a COPD. So cystic fibrosis can often be in the family of COPD, but here it's under other. Alkalosis, acidosis, again as a result of other diseases. Hypercapnia, hemothorax, pneumothorax, pleurisy, and sinusitis.